I'll start now. So thank you very much for the invitation to talk to you today. I'm Olivier Pardo. I'm a team leader at the Division of Cancer at Imperial College. And today I'm going to tell you about our latest research on the role of the kinase RISC4 in regulating drug resistance and metastasis in lung and bladder cancers. Because of time restriction, most of the data that I'm going to show you today will be in lung cancer cells, but please do remember that anything that I show you today is actually applicable to bladder cancer cells as well. So first of all, how did we come up with RISC4 as a target? And this came out of a series of siRNA screens that we performed in my lab, looking at response to chemotherapeutic drugs such as Taxol and cisplatin in bladder cancer cells. The same thing in lung, breast, and colon cancer cells. That was work we've done before in the lab of Julian Downward, and a cell migration screen that we had done in lung cancer. And out of the screen in bladder cancers, we found that 23 kinases regulated similarly the response to Taxol and cisplatin in the cells that we used. Out of these, we validated 13 in 3 additional bladder cancer cells. And when we cross-correlated the results for all these screens, the targets that came up on top was RISC4, showing that it regulated both drug resistance and metastasis. So what is RISC4? RISC4 is a member of the RSK family. There are 4 members in humans, numbered risk 1 to 4, and what characterizes them is a very high degree of conservation, and you can see this here between family members. The N-terminal kinase domain, which is the one that mediates phosphorylation of substrates, is almost identical between all members of this family. Another really interesting thing about these kinases is they have 2 separate kinase domains: an N-terminal kinase domain, which, as I told you, phosphorylates substrates, and a C-terminal kinase domain, the function of which so far is limited in our knowledge to just phosphorylating the N-terminal kinase domain for activation. So despite the fact that they have such a high degree of conservation, what I'm going to show you today is that RISC4 and RISC1 has opposite effects in many cancers and many cancer cells. And this has clear therapeutic indications, and we're going to discuss this in a moment. So I told you that we found it in lung cancer initially. So what's the situation of RISC4 expression in lung cancer? If we compare normal tissue with primary lung tumors, what we can see is that normal tissue is 100% negative for expression of this protein. On the other hand, if we look at primary tumor, almost 60% of primary lung cancer overexpresses RISC4. And if we deconvolute this into the separate types of lung cancer, we can see that adenocarcinoma has got the highest proportion of positive cases for RISC4, and also the highest expression levels of this kinase as compared to small cell and squamous cell carcinoma. Not only is it overexpressed in the primary tumor, but when you go on and compare primary and metastatic lesions from the same patient, you can see that RISC4 is further overexpressed in 50% of metastatic lesion as compared to primary lesion in lung adenocarcinoma. And this is not only limited to the human system, but if we go into mouse model of adenocarcinoma, we can see that RISC4 expression level increase between the tumors that are not in metastatic primary site and a metastatic site for these tumors. And this special role of RISC4 in terms of higher level of expression and higher proportion of patients expressing this kinase in adenocarcinoma versus small squamous cell carcinoma is shown in survival impact. So patients with higher expression of RISC4 do far poorer in adenocarcinoma than patients with low level of expression of this kinase. While in squamous cell carcinoma, there is no statistical difference between the two. So why is this? Why is it that patients overexpressing this kinase are much worse off than patients with low expressions? And the first thing that we noticed when we started modulating the level of RISC-4 in lung cancer cell lines is that if we silence RISC-4 in these cells, we sensitize them to cisplatin and Taxol, two drugs that are used in the treatment of this disease. And this is because when we silence RISC-4, we promote the activation of caspases in these cells, so the apoptotic program. On the other hand, when we overexpress RISC-4, we end up with the opposite phenotype, and the cell become more resistant to therapy. And this is associated with an inhibition of cleavage of caspase and their substrate, meaning that we are inhibiting the apoptotic process. So basically, overexpression of RISC-4 make these cells resistant to apoptotic cell death. Also, what we noticed is that if we silence RISC-4, we inhibit cell migration in lung cancer cells, and this is the opposite when we overexpress the kinase. So if we overexpress RISC-4, we promote cell migration. And so that means that tumors that will have higher level of RISC-4 will have higher propensity to form metastasis, which matches with the data that we had in terms of comparison of RISC-4 expression between metastatic site and primary site. And the reason why we get inhibition of cell migration when we silence RISC-4 in lung cancer cells is because we are reverting epithelial mesenchymal transition. So when we silence RISC-4, the cell cluster together, we can see increase in cell-cell contact, increase in cortical actin, and this is associated with increased E-cadherin expression and decreased N-cadherin and vimentin expression. So a reversal of the EMT and therefore mesenchymal epithelial transition of the silenced cells. And when we looked into the mechanism of how this was happening, we found out that this was dependent on the effect of RISC-4 on the activity of relay, the mediator of the NF-kappa B pathway, whereby when we silence RISC-4 in lung or bladder cancer cells, we see a decrease in the activity of relay in these cells. And this scheme here is to summarize a lot of data that I don't have time to go through with you today. And what we found is that the reason why this happens is because RISC-4 phosphorylates P300 on the site that is auto-inhibitory for this acetyltransferase. And when it is inhibited, basically relay is unable to stay within the nucleus and leads to transcription of target genes. On the other hand, when RISC-4 disappears, now P300 is uninhibited, acetylates relay exits the nucleus, it goes into the cytoplasm, and targets genes that normally mediate epithelial mesenchymal transition are inhibited. So we've seen inhibition of cell migration, but we can further show that this is associated with an inhibition of invasiveness of these cells. So we developed a collagen matrix invasion assay, and we can show that when we silence RISC-4, we inhibit the ability of lung cancer cells to invade upwards towards a chemotactic growth factor. But invasion per se is not the only thing determining the ability of cells to form metastasis in vivo. Once the cell has penetrated within the blood vessel, it needs to be able to survive in suspension, and that means it needs to be resistant to anoikis, cell detachment induced apoptosis. And so we developed an assay to compare the ability of cells to survive in detachment versus adhesion conditions. And what we found that RISC-4 silencing decreases the survival of cells in suspension. So it decreases the ability of the cell to survive anoikis. And this is very selective for this isoform, because if we silence RISC1, we found no statistical significant difference between control and RISC1 silence condition in this assay. So to summarize, the cells that are silenced for RISC4 have decreased cell migration, decreased cell invasion, and a decreased resistance for anoikis, which may explain the inability to form metastasis in vivo. So this was all in vitro. How do we prove that indeed this is what's going on in vivo? So we made cell clones that are CRISPRed out for RISC4 expression, and we injected it subcutaneously into mice and monitored growth of these tumors. And I think you can appreciate here the fact that both RISC4 CRISPR clone are less able to form tumors in time than the untargeted cells. And this is associated with also increased sensitivity to chemotherapy, the like of which we've seen in vitro, with these tumors with the control cells being fairly resistant to chemotherapy with cisplatin. But now if you silence RISC4, you can have a statistical difference in the response of these tumors to chemotherapy. On top of that, the CRISPR cells are less able to form distant metastasis. So if we inject the CRISPR cells in the tail vein of animals and monitor the ability of these cells to form tumor in the lungs, we can see that the CRISPR cells are almost unable to form lung metastasis as compared to the control cells. So all this taken together suggested that RISC4 was a very good potential therapeutic target in lung cancer, but we quickly understood that if we wanted to target RISC4, we needed to be extremely specific, and that no pan-RISC inhibitors could do. And the reason for that is everything that I just told you about RISC4, if you actually go and silence RISC1 instead, you find the total opposite. So if you silence RISC1 in lung cancer cells, you have increased invasiveness in 3D collagen, you have increased resistance to chemotherapy. And if you go on and silence both RISC1 and RISC4 at the same time, the effect of the silencing of each target individually is canceled out. So you have no change whatsoever. You don't have the resistance due to RISC1 silencing. You don't have the sensitization due to RISC4 silencing. You have nothing whatsoever. So that told us that we couldn't use the pan-RISC inhibitors that are commercially available, and that we had to develop a RISC4 selective compound. So we did a drug screen for compounds that would target the activation of RISC4. And out of this drug screen came a hit that is moxifloxacin, which is a floxacin antibiotic. And we could show that moxifloxacin was able, in a dose-dependent manner, to inhibit activation of RISC4. So we did a subscreen where we took 26 compounds from the floxacin family, and what came out of this subscreen is that 50% of compounds were unable to inhibit RISC4 activation, while 50% of compounds were able to be RISC4 inhibitors. So this told us immediately that the antibiotic properties of this compound and their ability to inhibit RISC4 are two separate things and are not linked. One of the best compounds that came out of this subscreen was trofloxacin, which turned out to be an allosteric non-ATP competitive inhibitor of RISC4 activation. And when we use this compound now in cells, we can see that as for RISC4 silencing, trofloxacin sensitizes these cells to chemotherapy and inhibit their ability to invade in collagen matrices. On the other hand, if we take ciprofloxacin, that I showed you in the previous slide was incapable of inhibiting RISC4 activation, we can see that this compound is inactive in the cellular assays. So again, this was in vitro. What happened in vivo? So if we look in a xenograft model for A549 cells, we can see that trovafloxacin on its own is as efficient in inhibiting tumor growth as cisplatin. But that's not saying much, because cisplatin, as I said, lung cancer, non-small cell lung cancer cells are fairly resistant to chemotherapy. But now if you combine trovafloxacin with cisplatin, for the first time you start seeing tumor regression. And this was also observed in a genetically engineered mouse model where adenocarcinoma is obtained downstream of KRAS activation and deletion of P53. And here you've got the vehicle-treated only control and CT scan with tumors appearing in different, individual tumors appearing in different colors here. If I was to show you the cisplatin condition, it's pretty much indistinguishable from this picture. On the other hand, when you combine trovafloxacin with cisplatin, I hope you can see that you have decreased in the number of lung nodules and size of lung nodules as well. So this was in lung cancer, but we had the opportunity to test this combination of trovafloxacin and cisplatin in bladder cancer patient explants, and we had 4 patients here. One patient turned out to be exceedingly sensitive to cisplatin, so cisplatin only led to total disappearance of viability in the tumor explant. But in 3 patients, what we found, and you can see this through Bliss factor calculation here, is that the association of cisplatin and trovafloxacin was synergistic and led to favorable explant cell death compared to each compound used separately. We also went on to look at an old clinical trial that had been run where levofloxacin, another of the floxacin family that is able to inhibit RISC-4, levofloxacin had been administered to cancer patients, not only lung cancer patients in order to test the ability of this compound to prevent chemotherapy-associated infections. And what the authors at that time couldn't understand is that when you had eliminated the infection factor, you could still see that levofloxacin increased the survival of lung cancer and other cancer patients as compared to patients that were given a placebo on top of their chemotherapy. So it meant that levofloxacin was able to promote the survival of this patient independently of the infection status. And we now are able to come up with a possible explanation for this, which is through the inhibition of RISC-4. And to demonstrate this, we are now trying to initiate a placebo-controlled phase 2 clinical trial in lung adenocarcinoma, where we're going to stratify patients based on RISC-4 expression and treat with chemotherapy plus and minus levofloxacin as a RISC-4 inhibitor. So how does trovafloxacin, or floxacins in general, succeed in inhibiting RISC-4? So I told you that we found out that they were allosteric inhibitors that prevented activation of RISC-4. And as you can see here through this thermal shift assay, trovafloxacin is able to bind RISC-4 only when RISC-4 is inactive. Once RISC-4 is activated, trovafloxacin does not bind to this protein anymore. And so the binding of trovafloxacin to the inactive RISC-4 is preventing the activation. And so if we look at where trovafloxacin binds, if we do deuterium exchange mass spectrometry, we find that trovafloxacin binds to the C-terminal region of the N-terminal kinase domain. And when we crystallize the N-terminal kinase domain and perform Markov transient analysis, we found that this particular site corresponds to a novel allosteric site on this kinase. And if trovafloxacin binds to this region, it basically prevents propagation of the signal to the activation loop of the kinase, and therefore prevent activation of RISC-4. And the reason for that is that this new allosteric site is the site that normally accommodates the phosphohydrophobic motif of this kinase. So the phosphohydrophobic motif is at the end of the N-terminal kinase domain. And during activation of the kinase, it goes and folds over the N-terminal kinase domain, binds to this allosteric site, and enable activation of the kinase. So when trovafloxacin binds to that site, it competes out the ability of the hydrophobic motif to go bind to this site and therefore prevent activation. So in summary, what I showed you today is that RISC-4 inhibition delays the growth, sensitized to chemotherapy, and inhibits invasion of lung cancer cells in vitro and in vivo. That some floxacins, such as trovafloxacin, should be a good chemical starting point to develop new RISC-4 inhibitors. And we're currently developing derivative of trovafloxacin that we believe are not devoid of antibiotic ability, but retain their ability to inhibit RISC-4 activation. And it looks like administering floxacins at the moment to patients undergoing chemotherapy may be able to extend the overall survival of lung cancer and possibly bladder cancer patients. So this work has been possible thanks to a long list of collaborators that have helped us with every aspect of this work. And in my lab, Luxemon and Stelios were two very gifted PhD students who drove this project. Rajat was a postdoc that participated to all aspects of this project and also other projects in my lab. Michael Seckel is a professor in medical oncology who runs the lab with me. And this is a recent picture of my lab showing MRes students that participated to some aspect of this work. So half an hour is a short time to summarize all that we've found on RISC-4 so far. And if you're so inclined, please go and read our paper on Science Translational Medicine that got recently published and where we develop some of the aspect of what I told you today further. Thank you very much for your attention, and I'll be happy to take questions now.
Yes. Thank you, Dr. Oliver. Is there any questions from audience?
I can ask Dr. Pardo a question, please. Thank you very much for the wonderful presentation. It's really fantastic and refreshing. I'm a clinical oncologist myself, and but I've shifted a little bit into the integrative oncology realm, and it's very nice and refreshing to be hearing some of the laboratory and research work again. So you're aware that in the integrative oncology realm there is the COC protocol from London and using like doxycyclines and mebendazole, etc. However, I do find the data that you have provided with the floxacins in general are more particular than using something like the doxycycline in treatment of the or blocking one of the pathways, because with the COC protocol they're just like blocking this pathway, that pathway, without actually studying if that person actually has that defective pathway in his body. So can I ask, with the levofloxacin, are you suggesting, is it like do you use it in pulse therapy like with the doxycycline?
Well, we're still trying to figure out how we would administer it. So I think the patient would be probably in receive levofloxacin constantly and then receive cisplatin or the chemotherapeutic drug according to the normal schedule for this compound. And so the only problem we have is that, of course, keeping a patient on antibiotic for an extended period of time is a problem. And this is why we're trying now to develop derivative of these compounds that do not have any more antibiotic properties, but are still a risk for inhibitors. An additional concern with some of the fluoxetine that we found very active, such as fluoxetine, is that they're associated with some very dramatic hepatic failure events. So for unclear reasons, some patients react very poorly and even die out of administration of fluoxetine. But this seems to be less of a problem with levofloxacin. So even though we think that levofloxacin is less active than fluoxetine, we think that it's still a potential inhibitor that we could give in the clinic. And as I showed, there is still a quite significant shift in survival in patients that were unstratified with this old clinical trial. So once we stratify patients for RIS4 expression, we could expect to have a better shift even.
So maybe we can give the whichever fluoxetine that we are using around the chemotherapy, and then in between the cycles we can just give them like high diversity probiotic, etc., like bacillus coagulans or fluoci, etc.
Yeah, I have to.
Yeah,
I have to say that data so far suggests that the activity of RIS4 inhibitor is not limited to chemotherapy. So there has been a paper that has been published pretty much in parallel with ours, which was in esophageal carcinoma, where they showed that RIS4 was involved in resistance to radiotherapy. So basically, I think the activity of RIS4 is to prevent apoptosis from taking place. So any therapy that actually is looking at inducing apoptosis in the tumor would benefit from having RIS4 inhibition.
This is fantastic. Thank you very much.
Welcome.
Is there any question from audience?